Hello, guys. Good day to you wherever you are. Today, I'm your manual therapy tutor, Oluwaleke Shokunbi. I'll be taking you on cervical and lumbar traction. The cervical and lumbar traction is one of the techniques we use in manual therapy to resolve radiculopathy and is enjoying recent evidence in support of its efficacy, particularly the intermittent traction in the management of nerve root pain, either in the cervical or the lumbar spine. So it is also worth the effort to quickly go through our notes on what we have to do for cervical and lumbar traction in case we see a patient that have radiculopathy in the cervical spine or in the lumbar spine. Okay, so before we go into the traction itself, we need to talk a little bit about radiculopathy. What is our understanding of radiculopathy? Radiculopathy is a word coined from two words, radiculo and pathy. Radiculo itself implies nerve roots, and pathy means disorder. So when you say radiculopathy, you are talking about disorders of the nerve roots. So talking about disorder of the nerve root. When the nerve root is compressed, it can get inflamed. When it's compressed, it can get inflamed and it can start manifesting some symptoms. Is at that point we say there's radiculopathy. So ideally, substances that could compress a nerve root are many, but the major one, the chief one among them, is the movement of the disc, intervertebral disc where its original place, which is what we call disc herniation. Disc herniation is the chief cause of compression on nerve root. All right, so whenever there's disc herniation, there will be compression on the nerve root, there will be inflammation, and all the signs, clinical features of radiculopathy will follow. But beside disc herniation, a little bony outgrowth from the margin of the vertebrae, or we call marginal osteophyte, could also compress on the nerve root. Shifting of the vertebrae. Vertebrae can either shift forward or shift backward, which is what we call spondylolisthesis. Anterolisthesis is when it shifts forward. Retrolisthesis is when it shifts backward. Either of the shifts could result into compression on the nerve root. All right, there is a ligament that connects the distal part of the pedicels, the lamina that projects into spinal cord. That ligament called ligamentum flavum, connecting the lamina together. It could actually get swollen, enlarged, hypertrophied, and compress on the nerve roots, and that could also give rise to radiculopathy. But among all of them, the chief cause of compression on nerve roots is the movement of the intervertebral disc. All right, and whenever a patient is suffering from that compression, if it is happening in the neck, there might be pain in the neck. There could be referred pain to the upper extremities. There could be impairment of sensation along different parts of the upper extremity depending on the particular nerve root that is compressed. There could be abnormality of some reflexes in the upper extremities, brachial reflexes, brachioradialis, and tricep reflexes. If the radiculopathy is taking place in the lumbar spine, there could be pain in the lower back. The pain could be referred to the lower extremities, and some reflexes in the lower extremities, knee jack reflex, hamstring reflex, ankle jack reflex could also be affected. So these, in a nutshell, refer to the causes, definition, the causes, and clinical manifestation of radiculopathy. And this is in essence what I'm talking about. Right? In radiculopathy, you have the disc leaving its original space between the vertebrae, compressing on the nerve root posterolaterally or posterocentrally. The disc could move posterocentrally to compress on the nerve root, or it could move posterolaterally to come. You can see the nerve root coming from the side of the spinal cord. Yeah. But beside the intervertebral disc, osteophytes could do the same. Ligamentum flavum hypertrophy could also do the same. Spondylolisthesis could do the same. A little cyst could also form between the disc and the nerve root, and that could compress on the nerve root as well. But these are rare causes. The chief causes is the movement of the intervertebral disc. And because we said the chief causes is the movement of the intervertebral disc, it's better we stay a little time to explain some of the mechanisms involved. Now, in your basic knowledge of anatomy, you would have been taught that the intervertebral disc is made up of two sheath parts. You have the nucleus pulposus and the annulus fibrosus, right? The nucleus pulposus is the inner part, the annulus fibrosus is the outer part. Now, anatomically, the nucleus pulposus has a lot of more water than fiber. Let's make it as simple as it could be. I know the fiber are collagen, proteoglycoprotein fiber, but let's just say that the annulus has more fiber than water. The nucleus has more water than fiber. The annulus has more fiber than water. But as we grow, the nucleus tends to lose that water, so becoming more fibrotic in nature, becoming more like the annulus fibrosus in nature, and then it begins to push on the annulus fibrosus. So while it's pushing on annulus fibrosus, but annulus fibrosus has not really parted way, we could say there's disc prolapse. At the onset of generation, when it has lost its water, we can say, oh, this degeneration has taken place. But when the nucleus pulposus begin to push on annulus fibrosus, we could say there's a prolapse. By the time the annulus fibrosus give way and both of them result into pushing on the nerve roots, then we're going to say there's disc extrusion. And by the time part of the extrusion break away to go and get dislodged in other segments of the spine, beside the original place where the problem is happening, then we're going to say there's disc sequestration. So the symptoms that patients that come to our clinic will present with can vary depending on the nature of their pathology. A patient that is just having prolapse might not have a very severe symptoms like the one that is having extrusion. And the patient that's having extrusion might not have multiple level disc prolapse symptoms like the one that is suffering from disc sequestration. All right. So, ideally, what is left for the therapist is to confirm that there is radiculopathy, compression on the nerve roots, and then we want to apply a traction treatment, isn't it, to separate the compression. But how do we confirm this? Well, the gold standard for that confirmation is to do a radiological investigation, and the best of it we can do is MRI. Magnetic resonance imaging. When you do that, you'll be able to confirm the compression on the nerve root, and then you can proceed to the treatment. However, it is not in all cases that you find it easy straight away to go for MRI. There are many places in Africa where MRI machines are not available. There are instances where they are available, the cost is beyond the reach of the patient, and there's no sponsor anywhere. So there are also good clinical predictors, in form of tests, clinical predictor tests, that when we carry them out and they are positive, they are as good as using MRI to confirm the diagnosis of radiculopathy. So this battery of tests are called predictors that are diagnostic of cervical radiculopathy. One of them is Pauling test. We're going to describe that. There's cervical distraction test. There's neck rotation, and there is upper limb nerve tension test, all of which we are going to describe. Now let's go to Pauling test. In Pauling test, don't forget these are battery of tests that you can use to diagnose radiculopathy, even in the absence of MRI. If 3 out of these 4 tests are positive, then you can be rest assured that to a very high degree your patient is having radiculopathy. So in Pauling test, the patient might be having pain radiating to the left upper extremity, so the therapist will bend the neck to the right. He will use his proximal hand to apply a pressure on the vertex of the skull and push the pressure down the cervical vertebrae of the patient. And if the test is positive, patient will report pain in the neck radiating down the arm, or impairment of sensation radiating down the arm, or any of his clinical features radiating down the arm. Now you've got to take note that the therapist bend the neck away from the side of the pain. Another thing you've got to take note is that there will be no need for Pauling test if the patient is already feeling sensation down his arm, because we only use it to provoke that sensation. So it's only needed in patients that are not having that sensation already. but we are still suspecting radiculopathy anyway. But they are not manifesting that symptoms in the upper extremities. But if this patient is already experiencing symptoms in upper extremities, you don't really have to do a spalling test. It's just like provoking their symptoms, which is quite unnecessary. All right, so spalling test is only needed when patient is not manifesting symptoms in the upper extremities and we are still suspecting that there could be cervical radiculopathy. Okay. Now, the second test is cervical distraction test. As you can see in that test, the patient could lie prone, holding on to the edge of the bed, and then the therapist puts his proximal hand on the chin and distal hand under the occiput. One foot of the therapist is ahead of the other one is behind. So the participant will hold the neck like that and lean back on the rear leg. As he lean back on the rear leg, he will take some of the weight of the neck and the head with him. And that will cause some relief of compression if there's radiculopathy in the neck. And what do we expect the patient to say? The patient could say, oh, I don't feel this pain again. Or patient could say, oh, I cannot feel the pain in my upper extremity again. It's just in my neck. That means the pain has centralizes. So how do we know how much to push back when we lean backward? The moment you lean backward and patient reports centralization of symptoms, i.e. the pain in the upper extremity is no longer there or the pain has reduced, that's the point to stop. And that means cervical distraction test is positive. Now, just like I said for upper limb nerve tension test, you also need to know when cervical distraction test is needed. Cervical distraction test is only needed when a patient is already feeling symptoms in his upper extremities. I said it is not needed. Spalling test is not needed when patient is feeling symptoms in his upper extremity, but cervical distraction test is needed when the patient is feeling symptoms in his upper extremities. How much force should we apply? Maybe roughly about 14 kg, but theoretically, immediately the patient experiences centralization of symptoms, then we've got to stop. Okay, we've got to stop. All right, the third test is the upper limb nerve tension test. All right, the third test that is very diagnostic of radiculopathy is upper limb nerve tension test. You know, many of the brachial plexus, they emanated from the axilla and they pass through the axilla into the upper extremities. So stretching the upper extremities somehow results into stretching of their nerve root, and that could aggravate their symptoms if they are already being compressed, as we have described in radiculopathy. I hope you get what we are explaining here. Now, there are three types of these tests. We have upper limb nerve tension test A, test upper limb nerve tension test 1A, and then we have 1B and we have 2. Now, upper limb nerve tension test 1A is said to be median nerve bias because it takes care of the nerve root of median nerve C5, C6, C7. It is also very important. This one is more important among the rest because radiculopathy in many patients usually happen at C5, C6, and C7. You understand? That's where radiculopathy happen in most patients. So it is much more popular. The upper limb nerve tension test 1A, which is described on this slide, is much more popular than 1B, which is radial nerve bias, and 2, which is ulnar nerve bias. But whichever one you use, you will get consistent result. But I prefer to use upper limb nerve tension test 1A because it will tell you anyway if there's radiculopathy in any part of the spine. So how is that nerve sliding test carried out? Well, you get a patient to lie down supine, you depress the shoulder. You know, by the time you depress the shoulder, you are actually stretching anything that connects the neck and the shoulder together. So the shoulder has to be depressed and the elbow has to be, well, you can come from flexion and go into extension of the elbow. Then the forearm will have to be supinated, the wrist will be extended, and the finger will be extended. You will agree with me that by the time you finish all this maneuver we've just described, patient symptoms will increase. But that's not the end of the test. At the end of that, you now ask the patient to turn his neck away from you. That's to turn it contralaterally, and that will cause more stretches, and that will increase the symptoms of the patient. At the end of the test, you now ask the patient to turn his neck towards you, but without lifting the shoulder. All right, the shoulder should still remain depressed. So by the time he turns his neck towards you, that will relieve some stretches on the nerve, and patient will experience a little decrease in symptoms. Okay, so that makes upper limb nerve tension test to be positive. So we have described Spalding test, which is the same thing as cervical compression test. We have described cervical distraction test. We have described upper limb nerve tension test. That's 3. If 3 out of the 4 tests are positive, you are good to go. But the 4th test really is just asking the patient to rotate the neck to the side of the pain. If the patient is able to rotate up to 60 degrees or more, then there is no radiculopathy. The likelihood that there's radiculopathy is very small. But if the patient is not able to rotate up to 60 degrees, then there is high likelihood that there is radiculopathy, right? So if 3 out of these 4 tests is good, we might as well assume to a reasonable extent that there is radiculopathy. Is that clear? Now, there are other tests that we can do, neurological tests, to confirm radiculopathy. Apart from these standard clinical predictors, we can test for the myotomes, we can test for dermatomes, we can test for reflexes. Now, what is myotome? A myotome is a group of muscles innervated by single spinal nerves. For example, the muscles that make us to bend and extend the neck, they are all innervated by C1 nerve roots. Now, it's the C1 nerve root that innervate them. Now, we have 7 cervical vertebrae, but we have 8 cervical spinal nerves. It could have been 7 cervical spinal nerve and 7 cervical vertebrae, as each spinal nerve exits through the vertebratorial foramen, but the 7th cervical nerve splits into 2. One of it passes through the foramen and the other one passes under the 7th cervical vertebrae, and it becomes the 8th cervical spinal nerves. So we have 7 cervical vertebrae and 8 cervical spinal nerves. So what we're saying is that the 4th cervical vertebrae is what is responsible, is what enables us to bend and extend our neck. So if you ask your patient to bend his neck and is finding it difficult to do, or he cannot do it, it could as well mean because there's compression on the 1st cervical vertebrae spinal nerves. All right, so C1 and C2 controls neck flexion and extension, as you can see in the diagram here, and C3 controls side flexion. C4 controls shoulder abduction. If you try this on the right and patient can do it, on the left patient cannot do it, it could mean there's compression on C4 on the left side of the patient. Shoulder elevation is controlled by C5. So if a patient is able to lift or shrug his shoulder on the right and not on the left, it could mean there's compression on C5 on the left. Elbow flexion is controlled by C6. Elbow flexion and wrist extension, they are controlled by C6. I can see the therapist here stabilizing the shoulder and asking the patient to push into flexion against this resistance. If the therapist cannot feel anything, it could mean C6 is under compression and is good on the other side. C7 is responsible for elbow extension or wrist flexion, and C8 is responsible for finger abduction. So you can ask your patient to abduct and you put resistance on it. If they are not able to do it, it could mean that C8 is in trouble. C8 is for thumb extension and T1 is for finger abduction. Okay, so they are called myotome because they are all muscles supplied by one single spinal nerve. So the myotome for C8 are the thumb extensors. The myotome for T1 are the finger abductors. The myotome for C5 are the shoulder elevators. The myotome for C4 are the myotome for C5 are shoulder abductors, and the myotome for C4 are the shoulder elevators. Okay. Now, we also have these myotomes in the lower extremity. Remember that if there's radiculopathy in the lumbar spine, it affects muscle strength and sensation in the lower extremity. So the muscle that actually control hip flexors, the iliopsoas muscles, they are supplied by the nerve root that come from L1 and L2. So if the patient is not able to do hip flexion on the right, but is doing it on the left, it could mean that L1 and L2 is under compression on that side. L3 and L4 is responsible for knee extension. So if your patient is able to do it, that means L3 and L4 is healthy, no compression on it. But if they have problem doing it, it could mean because there's compression on it. L5 is responsible for ankle dorsiflexion, whereas X1 is responsible for ankle plantar flexion, right? So those are the myotomes for the lower extremities, all right? We also have dermatomes, as you can hear, the word derma implies skin, isn't it? So what is dermatomes? Dermatome will be said to be an area of the skin that is supplied by one single spinal nerve. An area of the skin that is supplied by one single spinal nerve. All the skin very close to the base of the neck are supplied by C4. The skin overlying the superior anterior part of the shoulder is supplied by C5. And the skin over the thumb is supplied by C6. The skin covering the index and the middle finger, C7, ring finger and little finger, C8. So if a patient is having compression on C7, right, he might have problem of sensation around the index and middle finger. All right, so as there are dermatomes, there are also myotomes. Okay, so these are the dermatomes for the cervical spine, and we also have for the lumbar spine, because that will have to manifest itself in the lower extremity, isn't it? So if there's lack of sensation, L1 is the one controlling the skin over the inguinal area. L2 is the nerve root controlling the skin in the superior lateral aspect of the thigh, and L3 is controlling sensation in the skin in the inferior medial aspect of the thigh. L4 is the medial aspect of the leg. L5 is the lateral aspect of the leg extending to the toe. And X1 is in the Achilles area. So this is dermatomes for the lumbar spine. It is your responsibility as a student of manual therapy or orthopedic physiotherapy to know all the dermatomes, all the myotomes, all the end fields, all the capsular pattern at the tip of your finger. Now, these nerves also control reflexes. They do control reflexes, all right, but not all of them. Like we have all of them from C1 down to C8 are involved in myotomes or dermatomes, but for reflexes, only C5 down to C7 that are involved, right? C5 is the one responsible for bicep tendon reflexes. So if you test bicep tendon reflexes and it's sluggish or absent, it could be because there's compression on it. But if you test it and it's exaggerated above normal, it could be because there's upper motor neuron lesion. There's a release from the central nervous system on the control of C5, and that usually happens in upper motor neuron lesion like stroke, like Parkinson, like any of those upper motor neuron lesion. C6 control brachioradialis tendon reflex, and C7 controls tricep tendon reflexes. C2 to C4 and C8 are not usually involved in reflex control. What happens when there is nerve root compression and the reflex is slowed down is called hyporeflexia, or when the reflex is completely absent, it will be called areflexia. They are all pointing to lower motor neuron lesion, but when the reflex is exaggerated, then it will be called an upper motor neuron lesion. Okay, so we will not forget that these nerve roots are responsible for sensation, for motor function, and for control of reflexes. Well, by and large, like I said, one of the chief treatments we use in the management of traction, in the management of radiculopathy is what? Traction. And recent evidence support the use of traction in radiculopathy, particularly intermittent traction. We're going to talk about that in a minute, but let's look at this first. When we say traction, What is traction? It's a form of manual therapy. Why? Because force is applied. When we apply the force between one segment of vertebrae and you distract it from another segment of vertebrae, what are you doing? You stretch the skin from outside, you stretch the muscle, you stretch the tendon, you stretch the ligaments, you separate the bone, you increase the joint space, and you relieve the compression on the nerve roots. That is what traction is doing. And when this compression is relieved, sometimes the object causing compression could be forced to go back to its original position, thereby causing a rather permanent cure in the act of radiculopathy. Now, we want to talk about different types of traction that we have. And we can describe types of traction, number one, based on the method of application. And number two, based on the continuous flow of force that is applied during traction. Now, based on the method of application, traction can be said to be manual, it can be mechanical, it can be motorized. When is it manual? When it is done with hand of the therapist. No machine is involved. When is it mechanical? Well, when it is done with any equipment that make it easier to do rather than using hand. Machines could be any equipment that make work done easier. It could be a bag of water, it could be a sandbag, it could be pillow, it could be any equipment that we use to apply traction rather than the hand of the therapy. It could be a mechanical devices that you have to control and set some parameters. Then we have a motorized traction. In a motorized traction, it is also mechanical, but part of the equipment is moving in order to exert the pulling force. So it's more or less like a mechanical traction. This classification is based on the type, method of application. But there's another classification that is based on how much force do we apply and how do we allow the flow of the force to be sustained. So under this category, we could have continuous traction, sustained traction, and intermittent traction. When do we have continuous traction? Now listen, class. In continuous traction, you use a very low force and you make the patient to stay in the same position for a long period of time so that very low force will overcome compression, create enough space, and patient will be all right. I said a very low force and for a long period of time, ranging from about 30 to 40 hours. In the real sense of it, continuous traction is a form of skin traction carried out by orthopedic surgeon. Well, when there's radiculopathy or similar impingement in different parts of the body, and they hope to resolve that with the means of traction. All right? But the one that many of our colleagues call continuous traction now is actually a sustained traction. Because in sustained tractions, we don't stay more than 1 hour. It's between 15 minutes to 1 hour, whereas continuous traction could last for 30 minutes, 30 to 40 hours. That's 2 to 3 days, more than 2 days. So in sustained traction, it's meant to last for within 15 to 60 minutes maximally, and the force that is applied in sustained traction is usually larger than the one that is applied in continuous traction. It is said that in sustained traction, textbook says we are allowed to use up to half of the total body weight of the patient, or 10%. We can start from 10% of the body weight of the patient up to half. So if I come to your clinic, I'm having a problem with my neck, if my weight is 60 kg, 10% of that weight is 6 kg. So on the first day, you can start me off with 6 kg and you increase it gradually. That's sustained traction. A larger force than continuous traction applied for a period of 15 to 60 minutes. But this is what many of our colleagues now call continuous traction. So you might heard me saying continuous traction in the course of this teaching. Don't worry, I'm still referring to sustained traction. I just need you to know that in the real sense of it, sustained traction is carried out by the orthopedic surgeon. What about the intermittent traction? Intermittent traction is just like sustained traction, 15 minutes to 60 minutes, but there will be a disruption of the flow of force within that 15 to 60 minutes. All right, there's going to be a pulling time when maximum force of pulling is exerted. There'll be a relaxing phase when less than maximum pull is exerted. Relaxing phase does not imply zero amount of force is pulling. No, there will still be a pulling force, but the amount of force is reduced during the relaxing phase. There will be a pulling time. That is the time for which the force will pull maximally, and there will be a time for the relaxing phase. So there are 4 parameters the therapist will need to decide if you want to use intermittent traction. What is going to be the maximum pulling force? What's going to be the pulling force during the relaxing phase? What's going to be the time duration for the maximum pulling force? And what's going to be maximum duration for the relaxing phase? And sometimes you can calculate this in ratio. All right, the pulling and the traction phase, you can put it ratio 1:1 or 1:3 or 3:1, depending on how the patient is doing. For example, if a patient comes and the pain is still a bit of a problem, and the radiculopathy, I can decide to use a pulling force and a relaxing force of 1:1. Or of 1:3, of 1:1. If I use a pulling force and a relaxing force of 1:1, it means that if I pull with 6 kg during the maximum pulling phase, I will also relax with 6 kg for the relaxing phase. If I use a ratio 2:1, that means if I pull with a maximum force of 6 kg, then I'm relaxing. During the relaxing phase, I'll be using 3 kg. That will be very ideal for a patient whose pain is very high, using ratio 2:1. But as the patient is getting better, you can reduce it to 1:1. You can even go to 1:3. So the resting phase, the pulling phase, the resting force, the relaxing force, you can vary based on ratio and based on the condition of the patient. Okay. Now, when we are dealing, let's talk about cervical traction first. When you are dealing with cervical traction, it's very important for you to know. You remember I told you at the beginning of this class that most radiculopathy happen between C5 to C7, isn't it? Now, if you ask your patient to sit upright with the neck in a neutral position and you apply the traction in a neutral position, most of the pulling force will be exerted on the upper cervical vertebrae, C1 and C2. It will be exerted on C1 and C2. But if you want the pulling force to actually get exerted on the lower cervical spine, where most of the radiculopathy take place, then you'll have to bend the neck to about 15 to 30 degrees before you apply the pulling force. So there is a positioning that is required to get the pulling force to the right position when you are doing traction. When you use a neutral position or 0 to 5 degree, it will cause separation in the upper cervical vertebrae. When you use 15 to 30 degree, it will cause separation in the lower cervical vertebrae if you're dealing with cervical traction. All right, you can see that here. C1 and C2, you use 0 to 5 degree. When you are dealing with mid cervical like C3, C4, C5, you can use 10 to 20 degree of neck flexion before you start pulling. And if you are dealing with C5 to C7, you can use 25 to 30 degree of neck flexion. And this is manual traction being applied there. So what do we see here? There are 3 possible options for the positioning of the hand of the therapist. When you are doing manual traction, the therapist can decide to put the proximal hand on the frontalis and the distal hand on the occiput, like he's doing here. 1 foot ahead, 1 foot backward. He will lean backward and then exert a pull on the head and the neck of the patient. Or the therapist can decide to put both hands at the side of the occiput of the patient, and with the aid of a belt, it will reinforce his pull, lean backward, and exert traction. You will notice that here, the head of the patient is almost neutral, neither flexed nor extended. So even if it is flexed, it's not more than 5 degrees. So majority of the effort due to this pull will be exerted on C1 and C2. but here it is flexed to about 20 degrees. So the effect could be exerted on C4, C5. And when you go to 50-degree flexion, the effect will be on the lower cervical spine. Do you understand that? The third position is to put one hand on the chin, one hand on the occiput, one foot ahead, one foot behind, and you lean back to exert a pull. Now, because this is manual traction, when you lean back to exert a pull, how long do you stay like that for? You can stay all like that for 60 seconds. And after 60 seconds, you can lean forward again to relax. When you are relaxing, you are not taking off the force completely. You only relieved it, maybe for about 30 seconds. Then you know you are using ratio 2:1. 60 seconds for pulling, 30 seconds for relaxing. After relaxing 30 seconds, you go back 60 seconds again, and you continue like that for 2 or 3 repetitions. You can actually do more than that if it is manual traction, because it is energy consuming. All right. All right. So that is manual traction for the cervical spine. Now, the mechanical traction. For the mechanical traction, it could be done with a water bag, like I told you. On the side of the water bag, you're going to see different calibration, 100 ml, 200 ml, up to 1000 ml. If you fill the bag up to 600 ml, then you're applying 6 kg. Because density of water is 1, so the weight of water is equal to volume of water. Although you pour 600 ml, which is volume, that will be equivalent to 6 kg. Because density of water is what? Is 1. So by the time patient is well positioned in the strap, like this, and the strap is connected to the halter, and with a rope passed through the pulley and connected to the water, and the water is allowed to fall free, like this, it will exert exactly the weight of the water in the bag on the neck. Don't forget, you've got to ask the patient to bend the neck to how much you want the effect to be felt in the lower part of the body. And with this, you just leave the patient there for 15 seconds, 20 seconds, that will be a continuous traction. All right. If you want to do intermittent traction, then you can use a motorized form, like the diagram below here is for a motorized wheel. So you just put on this machine, then it will ask you, do you want to do sustained or intermittent? Some machine will say continuous or intermittent. If you choose intermittent, then we'll ask you, what's the pulling force? That's what's the maximum force it will pull with during the pulling phase. And for the cervical, in most cases, we recommend that you start with 6 kg for an averagely built person. If you try 6 kg in the first week, next week you can move to 8 kg, the upper week you can move to 10 kg, but don't exceed 20 kg. Do you understand? When do you even know when to stop? I've told you before. Let's say you increase the weight to 6 kg. Patient said, no, I can still take more. And you increase it to 8 kg. You now ask the patient, what do you feel? And patient said, oh, I can't feel my hand symptoms again. That one has gone now. That is the point to stop. Once there is centralization of symptoms, you don't have to take it further again. Do you understand? So once you have programmed the machine to maximum pulling force during relaxation phase, duration of time for the maximum pulling, duration of time for relaxation, you just press start, and machine will continue to regulate itself throughout 15 minutes or 1 hour, whatever is it you have set the time for to, and then the patient will be completed and the treatment will be completed. Either you want to go 15 to 20 minutes, or you want to go like 30 minutes, or even up to 1 hour. Now let's talk about manual traction for the lower extremities. For the lower extremities, yes, manual traction still can be applied. Patient will be in prone supine lying. You can use a belt to secure the patient. A belt can be used to secure the patient to the table, or you can ask the patient to hold on to the edge of the belt. Take note, the proximal hand of the therapist is below the knee joints, whereas the distal arm of the therapist is above the ankle. So the therapist will like 1 foot forward, 1 foot backward. It will lean back And as it's leaning back, it's applying a pulling force on the knee. The knee will open, the hip will open, the lower back will open. It will sustain this pull for 60 seconds, like we said, for manual cervical traction. It will relax, but not letting off completely by leaning forward for maybe 30 seconds. Then it will go back and repeat it 2 to 3 times. So that is manual lumbar traction. Okay. Now for the mechanical lumbar traction, that's when we use machine for traction. Patient can choose to do it in supine or prone lying. Now, before we go to patient positioning, generally, to do mechanical lumbar traction, there will be need for a lumbar traction table, which is usually like a split table, whereby one part of it is fixed, it's not moving, and the other part that is connected to the traction machine can move. So there's a need for a lumbar traction table and a lumbar traction machine. This is a lumbar traction machine here. You can see the split I'm talking about here. Now this part will not move, but this part connected to the traction machine will move. This part of the table will move as the treatment goes on. When a patient is in supine lying, they will necessarily have to flex their hip and put the back of their thigh on a stool. How much flexion of their hip they did determine where will be open, where the traction force will be exerted in the lower spine. But some patients also prefer to lie prone like this, and if that is what they preferred, they can also be treated in prone lying for lumbar radiculopathy. Right? So what do we say about the angle of the hip? If the hip is flexed very high, like 75 to 90 degrees, it will only cause separation around L3 and L4. But if the hip flexion is limited to 60 and 75 degrees, that will cause separation between L4 and L5. So this is going to do L4 and L5 because it's not up to 90 degrees. But the hip flexion is taken to 90 degrees, is going to cause separation between L3 and L4. All right. Now, the parameters that we use for lumbar traction slightly different from that of cervical. Lumbar is thicker and can take more a load than the cervical. I advise that we start with 6 kg for the cervical and you can move up to 10, 12, but don't exceed 20. Whereas for lumbar, for an averagely built person, we can start from 10 kg. All right, you can start from 10 kg. Weight on the first session. After first week, you move up to 12 or 15. And third week, you move from 15 to 20. And what I said about the evidence in terms of traction and radiculopathy is that intermittent traction now is what is recommended based on evidence. So that means you have to set the maximum pulling phase, pulling time, pulling weight, the weight for the relaxing phase, and duration of time for relaxation. It can be in any ratio 1 to 1, 1 to 2, 2 to 1, 2 to 3, depending on the presentation of the patient, as we have earlier described. All right, how often should a patient do the manual traction or mechanical traction? If time and space allowed, traction treatment should be done every day, like Monday to Friday. Why? Because when we cause that separation, we get the patient feel better. But when the patient go back on their leg, gravity wants to return things back to status quo. So we have to quickly apply our treatments in a cumulative manner so that we can achieve the therapeutic effect that we are hoping to get. That's why it's better we do it every day. But if the patient cannot do every day, maybe because of one commitment or the other, then the patient could also try to do like twice in a day for 3 days, in the morning and evening, then a rest, then in the morning and evening, then a rest, then in the morning and evening. There's no way one treatment of traction per week is going to help. that might not really help. It's also very important that when you finish with the traction, with that cervical lumbar, you allow your patient to rest for a few minutes and ask them questions about dizziness. If they feel dizzy or they feel uncomfortable, then you ask them to lie down until they feel better before you will allow them to go. All right? A good traction treatment combined with other physiotherapy treatment shouldn't take more than 1 month to resolve the cases. What I do say combined with other physiotherapy treatment, not traction as a standalone. You need to do other form of physiotherapy treatment along with it. Now, things that you have to document after you finish treatment in your documentation, you need to include the position of the patient that you have treated. Is it supine, prone, sitting? You need to document the angle of pull for the hip joints. Were they kept at 60 or was the neck kept at 30? The amount of force during the hold and rest cycle, is it 3 to 1 or 1 to 3? Then do you use static or intermittent traction? What's the total duration? How did the patient respond after the treatment? How pain, function improved? You need to record this as an important aspect of documentation. Then in case you don't have a manual traction in your practice for the lumbar spine, you can still do positional traction. All that is needed is separation at the affected segment, isn't it? Separation at the affected segment. So all you have to do is to get like 2 or 3 pillows or even more or rolls and get the patient to lie on the good side. So in this case, this patient is feeling radiculopathy on the right side going to the leg, so it's lying on the left side. Then you put those 3 or 4 pillows on the left side so that the head and the proximal part of the patient will pull his proximal part downward toward the planes, and the waist and the leg will pull the distal part downward, and that will cause separation on the left where there's radiculopathy. And you position the patient like that for 2 to 3 hours before the patient will stand up. That could have caused some separation and hopefully resolution of impingements. And combine that with other physiotherapy treatments, that will be called positional traction. Right? It could be done in the absence of mechanical device. Then we are rounding up with physiological effect of traction. What is the physiological effect? What happens to the body when traction is going on? Number one, the skin, the muscles, the ligament, the tendon, they are stretches. When ligament stretches, it generates forces. When muscle contracts, it generates forces. But when ligament stretches, they generate forces. So muscle, ligament, tendon are stretched, and they generate a force or a tension called centripetal force, which will cause the intervertebral disc to move back to its original space. Then beside the centripetal force, there is also increase in the space between the two bones that's causing compression. And this increase in joint space could move to resolve the impingements. That's the physiological effect. And that will lead to a number of therapeutic effects under which we have indication. Generally, traction is used for cervical and lumbar radiculopathy, but it's not limited to cervical and lumbar radiculopathy alone. Even when patient is having spondylosis, which is like osteoarthritis in the cervical and lumbar, we can still use traction, but you will use a reduced amount of force. When you notice a muscle spasm in any part of the body, you can still use traction, but you use a reduced amount of force for a reduced amount of time. All right? And generally, the contraindications for fractions are here: malignancy, infection, osteomyelitis, osteoporosis, because almost all this condition leads to a kind of compromise in the integrity of soft tissue. And when you're now applying a pulling force to skin, muscle, ligaments whose integrity has been compromised, patient is bound to experience more pain than before. And traction also do have some side effects. It could make the blood pressure to go up. It could cause headache and dizziness. Even the initial pain of the symptoms can aggravate because the muscle have never been pulled that way before. If the initial symptoms aggravate, all you have to do is to reassure the patient it's due to initial treatment things will be all right. Then you try to reduce the amount of force and the amount of pulling time until the patient gets used to the treatment. If dizziness, headache, elevated blood pressure comes up as side effects, again, you have to reassure the patient that they are not life-threatening. You can reduce the parameter of pulling and the force and the time duration of treatment that you do. All right. That these are specific indications and contraindication for cervical traction. It's more or less the same thing in both cervical and lumbar. Indication: herniated disc, spasms, degenerative changes, instability, spondylolisthesis. That is when the vertebrae shift forward. When it shifts forward is anterolisthesis. When it shifts backward is retrolisthesis. And contraindications again include all those conditions that can compromise the integrity of soft tissues and thereby produce a counterproductive effect during treatment. So this is going to be the end of our presentation of cervical and lumbar traction today. See you another time for another episode of teachings on manual therapy. Thank you.